Good morning and welcome to the Health Economic Forecast. My name is Dr. Amy Manderscheid and I'm currently serving as the Acting Dean for the Kirchhoff College of Nursing. We're so happy to have you here today. Thanks for coming. I'd like to begin this morning's program by introducing Fatma Milley. Dr. Fatma Milley is our Provost and Executive Vice President for Academic Affairs at Grand Valley State University. She joined GVSU in July of 2022 and earned her doctorate in computer science from the Université Pierre et Marie Curie in Paris, France. Prior to coming to GVSU, Dr. Milley served as the Dean of the College of Computing and Informatics at the University of North Carolina, Charlotte, where she led it through 5 years of growth in enrollment, retention, research, and broadening participation. Throughout her career, Dr. Milley has been embracing the transformational role that higher education has and can have in society. With this, I will turn it over to Provost Milley.
Thank you so much, Amy. Good morning, everyone. Seeing Amy's sheets, I told her your introduction of me is longer than my remarks. She asked me how to pronounce Pierre et Marie Curie. So I figured for a workshop, an event that is talking about health, it's interesting that, as you know, Marie Curie is the one who discovered radioactivity, and it's interesting. There are so many interesting things about her. She's the only person who won the Nobel Prize twice. She's the only person who won it in two different disciplines, chemistry and physics. She's the only person who, the first one was with her husband, Pierre Curie. And she died for her research. Actually, she died from her exposure to radioactivity. So how about that for starting an event about health? So I'm here really to give you short remarks of welcome. Welcome to one of the campuses of GVSU. I know many of you are from here and some of you are guests from the community. So welcome everyone. This is your university, the University for West Michigan, for Michigan. And this event reminds us of the mission of a regional comprehensive university like GVSU. Our mission is really to do everything we can to enrich the community, in addition to our mission of educating the future generation of citizens, professionals. It's also to provide intellectual leadership through the expertise and knowledge and wisdom of our faculty. It's through our partnership with the community, appreciating and engaging with the expertise and the wisdom and the knowledge of the community, and also fellowship by serving the community in whatever way makes sense. And in many respects, the event today illustrates all three. Thanks to our faculty from the Seidman College of Business, who will be sharing with us their expertise and their analysis of the economics of health. And thank you for the sponsors who made this event possible. And that is Priority Health, Blue Cross Blue Shield, and Blue Care Network. And I know there are many others who contribute to making this event possible. And to the hosting colleges, to the College of Nursing and the Wasoric Center who are hosting this event. So this is really an example of the university serving the community, the university engaging with the community, and the university being your campus, your partner in everything that is important. So I would like to thank you all for being here, and look forward to a very engaging and interesting panel.
Thank you, Provost Milley. Our college, along with the Seidman College of Business, serve as your GVSU host for this annual event, as Provost Millie had just described. The topics covered in these important dialogues directly impact all interprofessional healthcare providers, those who are still students, and those who are actively serving in our community. We are pleased to provide this platform to continue to showcase the health check data results about the health economic landscape in Western Michigan. A special thank you to our Health Economics Forecast Planning Committee for their ongoing support and leadership. We would also like to recognize our sponsors, Blue Cross, Blue Shield of Michigan, and Blue Care Network, and Priority Health. This event is both live and being recorded for later viewing. There will be 2 Q&A sessions this morning, and for participants here in the auditorium, you have question cards that will be collected, and a moderator will present the questions to our speakers. We will monitor the questions and present them as time allows. And just also one other reminder, in case you haven't seen it on the slides in front of you, the Health Check publication is live and available to you at this point. It is now my pleasure to introduce Dr. Jerry Simons, economics professor in Seidman College of Business, to moderate the first part of the program. Dr. Simons.
So thank you and good morning. Health Check presenters today are Drs. Daniel Montanera and Erkman Aslim, who both joined Grand Valley in 2020 as assistant professors of economics in the Seidman College of Business. Dr. Montanera earned his doctorate in economics from the University of Western Ontario in 2013. He was previously a faculty member in the Institute of Health Administration at Georgia State University. He specializes in health economics and microeconomic theory, studying defensive medicine and its impacts on healthcare spending and access to care. He also investigates applications of auction theory in designing efficient health insurance exchange mechanisms. He's published his research in the Journal of Law, Economics and Organization, of Information Systems Research, Manufacturing and Service Operations Management, and the European Journal of Health Economics. He has served on the editorial board of the journal Healthcare Management Science, and in his consulting work has collaborated with Mathematica Policy Research in developing guidance for states regarding the best ways to incorporate competitive bidding into their procurement processes in Medicaid managed care programs. Dr. Aslim earned his PhD in economics from Lehigh University in 2018. He specializes in health, labor, and public economics. His current research is on the impact of public health insurance on health and labor market outcomes. He also studies the interplay between medical innovations and health inequities. He has published in various academic journals, including Labor Economics, Journal of Policy Analysis and Management, and the Journal of Substance Abuse Treatment. Dr. Aslim's research has been featured in Time Magazine and Freakonomics MD, among many other national and health and local media outlets. And I believe we're going to start with Dr. Aslim.
Perfect. Thank you so much for coming. We are very excited to share new insights from this year's Health Check report. We hope that our findings will inform health and healthcare related decisions in our community and also inform policy decisions as well. This is a joint work with my colleagues, Daniel Montanera and Jerry Simons. So I would like to first provide a preview of our key findings from this year's report. The first finding relates to health insurance and healthcare access. Similar to our previous year's report, disparities still exist in terms of both health insurance and healthcare access, but there has been improvements during the pandemic on both ends. However, there were certain waivers, Medicaid-related waivers during the pandemic, and some of these provisions were lifted in 2013. So we are going to briefly talk about the implications of those waivers and potential trends as a result of these policy changes. One key finding in this year's report relates to mental health and mental health problems. Last year, we highlighted that there was a spike in mental health problems in West Michigan that was coming from our 2020 data, beginning of the pandemic. And now this year, when we added the 2021 data, we have seen an increase this year as well, a potentially problematic increase in mental health problems, especially among minority groups, non-white individuals. We'll talk about some of the mechanisms, dynamics behind this increase. Is it really prevalence? Is it due to better diagnosis or other factors? And another key finding relates to e-cigarette use. There has been a substantial increase in e-cigarette use, vaping specifically, in both West Michigan and East Michigan. So we will divide both regions. Coma refers to West Michigan. Detroit region refers to East Michigan. And then in the second part of our presentation, my colleague Dan will show how emergency departments visits change in both regions. We have seen increasing trends in the Coma region, which started to look more like East Michigan. There's some evidence of burnout among hospital personnel. My colleague will also talk about that. And we continue to explore racial and income disparities in health outcomes. And this year, specifically, we have updated our methods, and there seems to be more income-related disparities in the outcomes that we analyze. Now, in our first part, let me briefly introduce the data that we will be using. It's coming from the Michigan Behavioral Risk Factor Surveillance System, and we get this data from the Department of Health. This year's analysis will cover years starting from 2011 through 2021. I would like to note that this is a self-reported survey. So actual prevalence rates may differ, but the good thing with the survey is that we can directly incorporate demographic measures. So we can analyze potential disparities. Sometimes that kind of information is not necessarily or readily available from administrative data sources. There is a data suppression rule. If we have a low number of observations and you notice that we are going to break down these outcomes based on race as well as based on regions. So if we have small number of observations, we are not going to report those estimates. And we are going to analyze, compare trends in West Michigan with the trends in the Detroit region. Here are the counties that we will include in West Michigan. The counties are Kent, Ottawa, Muskegon, and Allegan counties. For Detroit, we will look at Oakland, Macomb, and Wayne counties. Okay, so first key finding relates to Medicaid unwinding. I'll talk about what that means. But first, let's look at access to health insurance. This graph that you see plots individuals reporting not having health insurance by race. The blue line is for non-white individuals in West Michigan, and the red line is for non-white individuals in Detroit. And the remaining trends are for white individuals in both West Michigan and East Michigan. Now, you can see that disparities exist throughout, but one positive development is that the trend has been decreasing, right? So there has been improvements in access to health insurance, especially you can look at the pandemic period, 2020 and 2021. The increase in access to health insurance continued during the pandemic. Now, there were certain policy changes that contributed to health insurance take-up during the pandemic. There were multiple waivers that relate to public insurance, public health insurance, Medicaid. Some of those waivers affected how insurance-based providers. Some of them affected enrollment. And one of those provisions, an important provision, was the continuous coverage provision. So let me briefly talk about what this provision is about. So during the pandemic, states didn't do annual reviews of individuals, and they didn't check whether they were ineligible or not. They gained continuous coverage through these waivers, right? And it definitely allowed individuals to stay on coverage because people have changes in incomes, right? They become ineligible, and sometimes there's administrative burden. Even though individuals are eligible, they don't do the paperwork properly. So this continuous coverage really allowed individuals to have access to health insurance. But in 2023, these waivers were lifted, specifically the continuous coverage provision, and a lot of people lost coverage. So I want to look at this problem through two different angles. Did people lose coverage because they were no longer eligible after this provision was lifted? Or did people lose coverage because of administrative reasons, procedural reasons? For example, they didn't file the paperwork properly, right? So first of all, let's look at, despite improvements in health insurance access, we think that we currently don't have the 2023 data. We think that there is going to be an increase in the uninsured rate because of this lift in continuous coverage policy. And we can kind of see it in these numbers. Michigan is ranked the 11th state in terms of the number of disenrolled individuals. Approximately 355,000 individuals were disenrolled from Medicaid after this provision was lifted, right? And the question is, did these individuals become ineligible, or is it due to procedural reasons? Here you go. 83% of individual lost coverage due to procedural reasons. I think this has very important policy implications, right? If we can simplify the framework, assist these individuals, right, we can actually reduce the uninsured rate substantially, because these individuals, most of them are eligible. They meet the income threshold. It's just that they're not able to file properly. So paperwork is an important barrier when it comes to accessing health insurance. Okay, now we look at healthcare access, and similar trends show up. There have been disparities in healthcare access, but this declined relatively during the pandemic because people had access to health insurance. Of course, having access to health insurance doesn't necessarily mean that there is going to be an increase in healthcare access, but we see that correlation here. Now, I have done multiple studies looking at delayed care during the pandemic. So 30% of individuals delayed care during the pandemic. And the rollout of vaccines, especially the COVID-19 vaccine, substantially reduced delayed care. And people were returning back to the healthcare setting. Based on my own research, I found that people were more likely to seek elective care. And there was an increase in elective surgeries, including cosmetic surgeries. But there was also an increase in access to preventive care. And we kind of see that here. The COVID-19 vaccine was rolled out in 2021. We kind of start to see an uptick in access to preventive care. And that is very important because my training and some of these health insurance experiments done in the US showed us that not all kinds of delayed care is welfare reducing. But if people are delaying care that relates to chronic conditions, if people are delaying preventive care, that's potentially problematic. Okay, the second trend relates to mental health issues. You can see, we'll start with physical health first. There have been improvements in physical health. Despite disparities, we see, if you look at the red line, that's for Detroit non-white individuals. So there have been positive developments on that end in non-white individuals in Detroit region started reporting having better physical health, although we don't necessarily see a similar trend in the Coma region. But overall, in the past 3 years, there was a decline. There's just a slight uptick in 2021. So I think it's important to follow that trend to see whether poor physical mental health outcomes will continue to trend that way in the upcoming years. The more problematic issue that we found this year relates to mental health. If you look at that light blue line, that shows mental health problems among non-white individuals in Coma. We have seen that uptick in 2020. Now we have added the 2021 data this year, and it has continued to rise. So in 2019, 12.5% of individuals reported having mental health problems. In 2021, that percentage increased to over 25%, right? Now the question is, why, right? We know that there's a lot of research showing that pandemic affected mental health negatively. But another question is, maybe we are better at diagnosing mental health. Is that one of the things that factor? Maybe, but when we look at the share of adults that report having unmet care, that number is not negligible, right? 27.8% of individuals in Michigan have unmet need for counseling or therapy. So I don't think that trend could be explained just by having better diagnosis, because clearly some people in our state can't really access treatment, and it could potentially be driven by just having higher prevalence of mental health problems due to various reasons, including the policies during the pandemic. Now, there are other outcomes that correlate with mental health. One of them is opioid use, especially opioid overdose. We see a similar trend in Michigan. As you can see, opioid overdose increased during 2020 and 2021. 26 individuals per 100,000 have had opioid overdose. And that number is much higher than the average in the US, which is 24.7. Remember that opioid overdose accounts for 82% of all drug overdose deaths in Michigan. 82% of all drug overdose deaths. So that's a huge problem. And also, another outcome that correlates with mental health is suicide. We also see similar trends in the suicide rate, an uptick in 2021, and the average suicide rate in Michigan is slightly higher than the average suicide rate in the United States. The last trend relates to e-cigarette use in our state, right? First, let's look at cigarette use. There have been positive developments in the sense that less people report being current smokers in our state, especially if you look at that light blue line. Non-white individuals in West Michigan are less likely to be current cigarette smokers. So it seems like there has been a decline in cigarette smoking. But let's look at e-cigarette use. This includes vapes as well, right? So it has been trending upwards since 2017, both in West Michigan and East Michigan. Although, if you look at the levels in terms of percentages, it's much higher in Detroit. But in both states, it has been trending upward, right? Now, is this a problem? Yes, it is. Because if you look at this graph, this paper was published in JAMA, and it shows that in the past few decades, there was a decline in cigarette use and nicotine addiction in the US. And less people were struggling quitting nicotine. Take a look at 2020 and 2021. We now have more people reporting that they're struggling to quit nicotine because of e-cigarettes. So e-cigarettes reversed decades of decline in the percentage of US youth, especially US youth, struggling to quit nicotine. I would like to end with a few more statistics. Nicotine vaping is one of the top forms of substance use among teens, right? More than 2.1 million youth currently use e-cigarettes. More than 1 in 4 use e-cigarettes daily. Daily. And 9 out of 10 use flavored e-cigarettes, right? That was the marketing campaign. Just have these interesting flavors that attracted youth to use these products, right? And we could soon see the end of flavored tobacco products in Michigan because there are a package of bills, and I think our state is going to ban some of these products because there's a lot of research coming out about how dangerous vaping is when it comes to various health outcomes. So I will stop right here, and I will pass it over to my colleague, Dan Montanera. Thank you so much.
Dr. Aslam had about 3 important points he wanted to cover. I've got about 2.5. And I'm going to start with the half because it's notable, but I'm not sure whether it's a big deal or not because there's competing stories behind what's happening, and they have very different implications. I'm opening with our benchmarking community section. So this is based on American Hospital Association annual survey data. And what we do with this one is we compare Grand Rapids experience and a lot of important healthcare variables to different communities to tease out whether certain trends are Grand Rapids specific, so our region's specific problem, whether this is a statewide issue, a nationwide issue, and also an issue that maybe affects similar communities as us. So what are those communities? So we've got the national average in gold. We've got Detroit, and then in red, we've got what we call our benchmark communities. So what this is a weighted average of communities that are similar to Grand Rapids in terms of demographics, industry, underlying health characteristics. Buffalo, New York, Rochester, New York, Milwaukee, Wisconsin, and kind of the Louisville metro area of Kentucky and Indiana. What we're looking at here is outpatient visits per capita. And we've got a long run trend of rising outpatient visits per capita in Grand Rapids. It's the dark blue trend line. We've noted this as a fairly successful experience with basically keeping the sickest, the most severe, most costly cases in hospitals and being successful at less severe cases, keeping them out of an inpatient setting and dealing with on an outpatient setting. We can see now that there's been strong growth in outpatient visits per capita in Grand Rapids for 2 years now, whereas other communities experienced a dip. I need to note this isn't just Grand Rapids residents here included in our numerator. So this is any outpatient visits that were conducted in the Grand Rapids and Muskegon. So even people from outside, the influx of inpatient visits from those coming from outside are included here. I don't have a slide for it, but hospital admissions, relatively flat, marginal increase. What's interesting here is the next slide. So this is total hospital expenses, inpatient and outpatient, per admit, and it's coded per admission. And we can see Grand Rapids and Muskegon, the only one where there's a decline year to year. So this is despite admissions remaining flat and a big increase in outpatient visits. So 2 stories here. One more concerning than the other. The first is that providers in the region have realized new efficiencies, whether scale efficiencies, operational efficiencies, and they're able to see the same patients for a lower cost. That would be what we would hope is happening. But what might be a little more concerning is we could see less severe cases utilizing hospital services. Where the having it be it more a distributional thing, whereas the number of less severe, low cost patients utilizing hospital services increases, and it kind of pulls the average down, and that's a bit more of a concern because hospital services are a costly form of healthcare, right? Delivering care in that setting that could have been delivered elsewhere means spending higher than it could be. And that's also, again, a reversal of what we always viewed as a positive trend of Grand Rapids kind of keeping the less severe cases out of the hospital and serving really the most severe cases and having a high cost per admission. So whether it's a big deal or not, it depends on which of those stories is happening. This data, we can't distinguish which, but it's something to keep an eye on. My first big point that I want to talk about, what we're looking at is emergency department visits per capita. And you can probably see what I'm about to get at. All through the history of this report, Grand Rapids has essentially looked like the rest of the country in terms of utilization of the emergency department. And then Detroit has always been in kind of a tier on its own, roughly 25-30% greater ED utilization. In the year 2020 to 2021, Grand Rapids jumps from looking like the rest of the country to looking like Detroit. We go from having a 22% gap in ED utilization down to a 6% gap. And what used to be kind of, a Detroit problem now seems more like a Michigan problem. So the question is, why? And, this is only from a couple years ago. There's no scholarly papers about this. So relying on news stories at the time and interviews with providers for what's driving this. And there's a few reasons that come up. First is the timing of the Delta wave of the coronavirus. It's not clear why that would hit Grand Rapids, the timing it did, but it could be one reason. An early onset of wintertime viruses. So viruses that would normally hit in the winter and some of them, carry over to the next year, January, February. If those hit earlier on, in the fall, in the late summer and fall, that could be the reason behind what's happening here, that leading to trips to the emergency department. What's more concerning, and again, news articles noting this at the time as it was happening, contemporary news articles and our providers or boots on the ground noticing a disturbing rise in mental health related visits to the emergency department. So, attempted suicides, behavioral emergencies, crises, cases where a relative will dial 911 because there's somebody trying to hurt themselves or hurt others in the household, and having them taken down to the emergency department. I'll talk a bit more about this in a minute, but another thing that the news stories note was that this is particularly an issue among Medicaid patients, and young people. That there was they were disproportionately represented among this group arriving in the emergency department due to mental health related issues. This corroborates what Professor Aslam was talking about this kind of emerging mental health crisis. And we have some data later showing that it kind of corroborates, and it's at least circumstantially consistent with this group or with these patients being disproportionately non-white and non-privately insured. Quick note, I want to talk about burnout for a second. Last year, we were starting to see evidence of burnout in the first full year of the pandemic, but last year it was localized to Detroit. And by burnout, we're taking that to be declining hospital personnel despite increasing compensation. We now see that in the second full year of the pandemic, that now this burnout is spread everywhere. So all of our communities seeing declining hospital personnel. That's despite payroll and benefits per employee increasing in all those communities. In fact, it increased at the greatest rate in Grand Rapids. And Grand Rapids saw I think it was tied for the biggest percent decline in employees per capita, hospital employees per capita. So again, burnout, important issue to watch, and it's not a regional thing now. It's pretty much everywhere by 2021. Switching from the hospital data, we're now relying on data provided from our community partners at Blue Cross Blue Shield of Michigan, Blue Care Network, and Priority Health. This data is 1 year more recent. So this is now 2022 data, which is kind of nice because we can go back and look at last year's data and compare it against the American Hospital Association and see if we can, support certain stories or rule out other stories. What we do is keep track of spending on a set of chronic health conditions. So asthma, coronary artery disease, depression, diabetes, hyperlipidemia, and low back pain. Conditions that require a lot of care, a lot of expensive care, and for a long time. And we also keep track of healthy members. So these are members of these these are enrollees of these organizations who are between the ages of 30 and 39. They don't have any of these health conditions. And what was the last one? And their healthcare spending was under $450,000 for the year. So we classify those as healthy members. They're going to be important to the story that's coming up. In terms of year over year, mostly down real spending, which might be surprising. But remember, this is real spending. What's mostly bringing it down is the inflation, the year over year inflation. Nominal spending actually increased a little bit. But when you adjust and that raises real spending for previous years, year over year down, except for healthy members. You'll notice, and remember what we said earlier, that one of the emerging trends might be healthier members utilizing hospital services. And we can see that is kind of a Grand Rapids specific thing, the dark blue, compared to Detroit, where the cost of serving these healthy members went down. Another note about the emergency department visits. So this is why we think that the spike in emergency department visits is driven primarily by the non-privately insured, because here we have, excuse me, here we have emergency department visits by our privately insured patients. And year to year, we don't see very large percent increases last year to this year, or even from last year's report. So that this spike had to come from somewhere. And if it didn't come from the privately insured, then we're talking about the uninsured and the publicly insured, our Medicare, Medicaid patients. Turning to disparities. This is our third year looking at disparities. And we did an update to our data and our methods. So this is the first year we're using the 2020 census numbers. We wanted at least 2 years to do at least a 1 year, year-to-year comparison using the old census numbers. And also we have a richer data set from our community partners that lets us build more solid weighted averages for all of our variables. Probably most of the room doesn't care about that. I just wanted you to know how hard we worked. Okay, what we're looking here. We've got our two regions, the Coma region, so west side of the state, and the Detroit region. The middle bars, the red bars, are giving you the regional averages. This is for risk score. So this is an index capturing the underlying health characteristics of the population, risk factors, how sick they are. A higher number is bad. A higher number means a sicker population. And then we also broke out residents in zip codes that had the 20% of the population in this set of zip codes. But first, the zip codes with the lowest weighted average income, mean household income, that's the blue. No, that's the gold. And then the set of zip codes that have 20% of the population and the highest mean income. So this is showing us income disparities in average risk score. And what we've been saying for years is that the disparities look kind of similar. Income disparities about the same in Detroit region. How am I doing? I'm good. Detroit region and Coma region, pretty similar income disparities. We see, raised prevalence or lower prevalence by income in similar patterns. And, looking at it here, that's what you would think. But then you have to remember there's much less income, underlying income disparity in the Grand Rapids region compared to Detroit. And once you, work out a per percent difference in income, there's actually double the income disparity in the Grand Rapids region compared to Detroit. We never saw this before we updated our methods. For every percent difference in income in Detroit, the risk score increases by about 0.3%. It's double in Grand Rapids. Every percent difference in income leads to about a 0.67 increase in average risk score. So it's hidden, the graph hides it a little bit, but what this shows is risk score swinging much more heavily as you look at income across zip codes. This is not a problem we noticed before. It was masked by the old data and methods we were using. And this is a new problem for Grand Rapids that we haven't pointed out, that our vulnerable populations are suffering differently from the rest of our residents. You can see it here. We don't even have an income disparity in. We're looking at. I'm going to show you two slides of cardiovascular disease and risk factors. We don't even have an income disparity on the Detroit side. We have a regional disparity. There's a lot more prevalence of coronary artery disease in Detroit, but no real income disparity. Our blue and gold are about the same. We do have an income disparity in the Grand Rapids region, in Coma region. Never saw that before. And then for hyperlipidemia, same story. So we have a reckoning with our income disparities in health outcomes that we've never brought up before, that we never found it, except for updating our methods. That's an important message. On racial disparities, this report's a little bit more consistent than what we've seen before, that there are racial disparities on both sides of the state, but they tend to have the opposite pattern, which is interesting. And we've attributed this in the past to, we have differences across zip codes in terms of, racial demographics, but the Coma region doesn't have the same level of segregation that you find in certain neighborhoods and zip codes in the Detroit region, and how that leads to poor access to employment opportunities, public transit, food deserts, all these that comes with segregation as opposed to just having more diverse zip codes. I want to point this one out. So here, this is showing racial disparities in terms of depression. And this is, again, circumstantial evidence supporting the story that Professor Aslam told about the mental health crisis being disproportionately among the non-white communities of Grand Rapids. So we can see here that there's a greater prevalence of depression diagnosis among the zip codes with a large share of the population identifying as Black, compared to those zip codes where a very large share of the population identifies as white. We don't see that same pattern in the east side of the state. So again, attributing causality is hard for this report, saying that one thing is definitely causing, but there's the circumstantial evidence kind of supports one narrative as opposed to the other. And what emerges in both parts of our report is this mental health crisis that appears to be driven by certain vulnerable populations, non-white population, non-privately insured. Important to realize that problem when figuring out what to do about it. And look at that. Q&A. Thank you very much.
Dan, while you're fresh off that, could you tell us a little bit more about the change in the data and methodologies that you were just referring to with the disparities?
Someone does care about that? Really? Okay, where do I begin? So this is, again, third year of looking at disparities. And the first time we did this, the latest census numbers weren't ready for us yet, so we relied on what we had, which was the 2010. And then the next year, we wanted to do at least one year-to-year comparison so we can get an idea of the trend in these disparities. Were they getting better? Were they getting worse? So again, this is the first year we use the 2020 census numbers. And that's important because we're trying to find low-income populations and high share Black, high share white populations based on zip code. Well, the makeup of zip codes changes over time, right? 10 years can make a big difference in terms of gentrification and things like that. So we're more confident now that we're looking at the right zip codes when we're separating out by, when we're stratifying by income and by race. That's the big one. In the past, we only had data on patients showing one of these 6 diagnoses and healthy members, and we had to base our weighted average on that. But it has kind of this unfortunate mechanical effect of, for example, if suppose diabetes is very prevalent on the east side of the state, and so has a high share of member months, that kind of would mechanically push all the other ones down because all the shares had to add up to 100. So having a high prevalence of one would kind of artificially look like the other ones weren't so bad. But we received richer data from our community partners, a lot of hard work on their part, but they provided some more of this data where we don't just have these 6 diagnoses, we also have all member months that we could use when building our weighted averages. So now that whole mechanical pushing thing, that's not a problem anymore with our with this year's analysis.
Thank you. And Erkman, you talked about the e-cigarettes. Any policy recommendations you think of?
Yeah, definitely. So with these kind of issues, the first thing that comes is like a supply side intervention. So that's what the state is considering, just banned flavored tobaccos, flavored vapes altogether. That could be a good policy, but I'm always concerned with when it comes to supply side interventions, you will be raising the relative price of the product. And that kind of increases illegal sales whenever you raise the price. So when it comes to policies, I'm more about finding policies that reduces the relative price of the product. So there's also no room for illegal sales of the product. Because, there were other policy efforts like raising the age requirement when buying vapes, right? They raised it to 21, but we still see youth using e-cigarette vapes. They would ban flavored tobaccos. They did in the past, right, with Juul, but there was a loophole. And now these companies started producing disposable vapes, because the initial restriction didn't really cover disposable vapes. Now they're going to ban certain flavors. They're going to come with other flavors or other ways of selling it. So I think a good way to prevent this is to have effective educational campaigns about the health risks associated with vaping. Yeah, and engage parents, engage students, engage schools, engage youth organizations. I think that would reinforce this message and support healthier choices. That's my take on that.
And Dan, you mentioned at one point about inflation and how it's affecting the numbers. Could you expand on that at all?
Yes. So I already said something about the when you account for inflation, that makes the nominal increases actually shows decreases spending in real terms. So I talked about that. In terms of what implications of that this could be concerning news for hospitals, because what it's showing is that their real revenue or their real intake is declining. They might be receiving more money, but that money isn't worth as much as it used to be, and so in real terms, not receiving as much revenue from payers. I suspect their costs are not falling as well. Grand Rapids total spending being the exception. So it's something that I think hospitals need to be concerned about, and take into account that even if spending increases in real terms, they might not be increasing. And if their cost keeps rising, that takes already slim margins and makes them even worse. So it's the other implication of what the inflation story means for what we talked about today.
And Erkman, maybe just finishing up, you talked about the Medicaid unwinding trend. Any recommendations there?
Yeah, as we have seen with that analysis, a lot of people lost coverage, not because they were ineligible. Some people were ineligible. They had fluctuations in their income, and the threshold is you have to be below 138% of the federal poverty level. If you're above that, you can qualify for federal exchange insurance exchange subsidies. The state has a website, right? Healthcare.gov. But those individuals that qualify, there seems to be an issue there that they just don't do the paperwork properly. And this has been a problem since the start of the ACA, and even before that. I think we just need to simplify the system and have more outreach, have more assistance, because these are really people who are eligible. They just don't take up health insurance because they either just don't understand, they don't know how to apply for it, or even if they know the website, it's just too complicated. A lot of people don't also understand health insurance terms like premiums, deductibles, those cost-sharing items. That's why when we always see that when people make decisions about health insurance, they always go with the premium. They always choose the lowest premium, but they don't look at the cost-sharing items, and that really increases the risk of bankruptcy. There's a lot of people with medical debt because they just don't pay attention to those details. So I think there should be a lot more assistance when choosing health insurance. I don't know how AI is gonna play a factor here. I would like to hear more from our insurers and providers about the role of AI. I don't know, that it might be effective in certain ways that I can see, maybe simplify some of those terms. If the person inputs relevant information, then those AI softwares can come out with the optimal insurance for the person and potentially simplify the process. That's my take on that.
Okay. Well, thank you very much.
It was a true pleasure. What excellent information you had to share with us this morning. It is now my pleasure to moderate the second part of the program. We are honored to have several of our community leaders with us today to present and respond to key trends from the health check. It is a pleasure to introduce our panel presenters this morning, and we'll begin with Dr. Brandon Francis, Chief Medical Officer of Trinity Health St. Mary's. Dr. Francis is a psychiatrist with expertise in behavioral neurology. Our second speaker will be Dr. Ronald Grifka, who is the president of University of Michigan Health West. He is a professor of pediatrics at the University of Michigan Medical School and an attending cardiologist at C.S. Mott's Children's Hospital. And may I put in a plug to say, go blue. Our third speaker is Dr. Rima Shah, who is the Senior Vice President and Chief Medical Officer for Corewell Health Medical Group West, and one of the spectacular leaders I've gotten to know. in our community. Our final speaker is Elizabeth Hertel, the director of the Michigan Department of Health and Human Services. Before becoming director in 2019, Elizabeth was Senior Chief Deputy Director for Administration, and she is also a GVSU Laker. With that, we will begin with Dr. Francis.
Thank you for having me this morning. Let me spend some time with you. Thank you, Dean. Wonderful introduction. Thanks for having us. Thanks to our colleagues and professors. Thank you for the forecast. My name is Brandon. I am a neurocritical care physician and psychiatrist by training, and I'm fortunate to serve as the Chief Medical Officer for Trinity Health Grand Rapids. I want to have a conversation with you about our focus on the partnership in our community. At Trinity Health Grand Rapids, excuse me, when we start our conversations, we ground ourselves in our mission, vision, and values. This is our culture slide. So I'm going to share with you our vision, or our mission, just to ground us in our conversation today. We, Trinity Health, serve together in the spirit of the gospel as a compassionate and transforming healing presence within our communities. Please know, it's not just about healthcare. It's about being a transforming healing presence in our communities. And our vision is that we will be the most trusted health partner for life. Trusted partner. These are the kinds of things I want to keep in mind as we have our conversation this morning. You know, in our facility, we have wonderful colleagues, and we've asked them to write down what makes them proud to be part of our team. And this is from accountants to environmental services workers to colleagues and providers. This one we thought would resonate with you for our conversation today. I value my role in positively impacting the lives of people in my community. I am so lucky that I get to work with them every day. So to set the tone for this next portion, our lives begin to end the day we become silent about things that matter. We want to invite you to join us in being silent no more. We've just heard from our colleagues about disparities, and let's understand the definition. Preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health by populations that have been disadvantaged. This is a big task. So we need to understand what equity looks like. Let's take a visual. We hear our colleagues share things like, we give the same care to everyone. We treat everyone the same. That's part of the problem. Equal care is not what we're after. We're looking for equitable outcomes. We want to do whatever is necessary to achieve that equitable outcome. So we think about it in medical terms, it makes sense, right? If one person to get an outcome needs medication, someone else might need surgery. That makes sense to us. But the moment we say someone else might need childcare or transportation, we suddenly change our tune. It's the same idea. Let's look at a real-world example of how this can impact us locally. Our colleague was sharing some of the data around zip codes. And this is, I'm learning every day. For me, every day is a school day. And our president, Matt Bierzak, shared this information with me. Helps me to learn about how we think through zip codes. This is from the CDC. Life expectancy variation here in Grand Rapids. One community, Wilcox Park, 73.2 years. East Grand Rapids, 90.8. I'll wait. Six-minute drive from one to the other. So if we're going to attempt to address some of these issues, we have to have a roadmap because these are complicated, big problems. And we have a roadmap. We know we have to identify individuals, analyze data, but let's pause for a second. How many of us, by show of hands, have heard institutional officials, government officials, argue, I wonder how we can prove some people struggle more than others. I've heard that. I'm tired of hearing it. So this is roadmap to action, because that's what matters. So the future depends on what you do today. So I ask, what are you doing today for our future? What can you do today? I'm going to share a little bit about what Trinity Health Grand Rapids is doing today to address these things. These are actionable things. These are things we're doing right now. We know that there's a housing opportunity in Grand Rapids. We know it's really hard to get healthy. It's really hard to get jobs, have sustainable opportunities without housing. So we work with our community partners, Mel Trotters, help with emergency housing, working with Dégagé. That building you saw there was our Hope Lodge in the corner of our campus. We're partnering with Dégagé to give them administrative offices and 30 new beds for those that need homes, and wraparound services so they can get the care and resources they need. We're helping those most vulnerable in our community. And it's a break-even lease with community partners. Another thing we're doing today, this is our mobile mammography bus. It's a big bus, by the way. And we partnered with the community to find out where our community needs are greatest. And that's where we send the bus, which means we partner with churches, groups, food trucks to get people to come out. And then we connect them to providers and the care that they need. Because we know there's disparities in breast cancer rates and outcomes from breast cancer. Something else we're doing right now today, we partner with Strong Beginnings. This group is looking at what is it that young mothers need, especially Black and Latina mothers. What resources do they need? You know what's amazing? When you ask them what they need and connect them to resources, their outcomes improve. Reduced preterm births. Reduced very preterm births. Prenatal care gets better. This is another project we're working on with another community partner. Through grants and funding and partnership, over 4,600 households have served. 21,000 individuals have received over 90,000 pounds of fresh produce. You know what's incredible? When you give people fresh produce, you know what they do? They eat it. Who knew? I showed this slide last year because we've heard from our colleagues around the mental health crisis here in West Michigan. Really, it's a national crisis, but we have our own flavor here in West Michigan. And there's a continuum of care for mental health. You can't solve the entire problem just by having more hospitals, just by having residential groups or emergency rooms. The emergency room cannot be the answer. And all too often it is. So what are we doing today about this? I showed you that picture last year on the upper right. That's what the building will look like. Right now, the bottom left, that's what it does look like. We broke ground. We're building a brand new 96-bed hospital with our partners in UHS, coming in 2025. We're hoping to offload some of that from our emergency rooms, which you know clogged them up. That's not the place. They don't do the best job handling patients long term. We need to free them up to do the care they can do. Our Behavioral Health Crisis Center. I showed you the picture last year of what it could look like. That's what it looks like right now. We're in the process of converting one of our buildings into the first of its kind crisis stabilization unit. There's no wrong door. No insurance? No problem. 100% funded with our partnership. We're also increasing our outpatient psychiatry practice, increasing availability of outpatient ECT, electroconvulsive therapy for those with the most severe depressions. And we're integrating more behavioral health resources into clinics that are already existing. This is what we are doing today to help. Is it enough? No, it is not. But we want to invite you to join us, partner with us, let us partner with you. We can do this together. No one group can do it by themselves. You will hear that we're partnering with our colleagues from UMH West and from Corewell to solve our community problems. This is not a Trinity Health Grand Rapids problem. This is a community problem we can solve together. I'll leave you with the last quote. This is from Catherine McCauley, who founded the Sisters of Mercy. And they helped and developed our hospital, hence the name St. Mary's. Do all the good you can, by all the means you can, in all the ways you can, in all the places you can, at all the times you can, to all the people you can, as long as you ever can. Thank you for spending time with me this morning. I appreciate you.
Thank you. Good morning. Sam Regriff, I'm the president of U of M Health West and pediatric cardiologist by training. Thank you for having me here this morning. Great to spend some time with you and look forward to this discussion. A number of people have talked about diversity, equity, and inclusion this morning. I'd like to spend just a minute talking about a leader in our community. Rand Booker was a colleague of mine. She was the vice president of diversity, equity, and inclusion at U of M Health West. Prior to working with us for the last 5 years, she was at both Calvin and Davenport universities. Rand has built several amazing programs that were recognized both locally, statewide, and nationally. She had a relentless drive to create a culture of inclusivity that had a positive effect on many lives in our community. On Saturday, after a courageous battle with Lou Gehrig's ALS, Rand passed away. She was a leader in our community, and it's important to remember Rand, but it's also important to continue her quest to create a community that's inclusive for all. So I just wanted to pass along the great work that she did. The funeral tomorrow at Calvin Chapel. But anyway, thank you, Rand. With that, I'd like to change, obviously, now to talk about Health Check. Can you believe this is the 15th year of Health Check? I mean, it's amazing the work that is done at Grand Valley University, analyzing our health and healthcare, comparing to other communities. Incredible data, well-researched. In summary, really, thanks to Grand Valley for supporting this great work, because it is helpful, letting us really give a great idea about what's happening about the healthcare in our community and how we can move forward with it. As I round in the hospital, I try to get around the hospital for a couple hours every week. And you hear terms used more and less frequently, but I thought I'd throw these terms out, kind of interesting. Don't hear, fortunately, too much anymore N95 or social distancing or Delta. Unfortunately, we do hear too much about fully staffed nursing units. Increasingly, you're hearing people talk about return to office, mental health access, and workplace violence. I also get a little concerned sometimes when I hear people talking about virtual visits, Chat GPT, and 340B, because these are certainly all topics that are hot topics in healthcare. In 2018, I gave this talk to the University of Michigan Health Board of Directors. I just looked at as much as I could find. I found there are at least 19 healthcare systems in the state of Michigan in 2018. I suggested that in 10 years, there may be just 7 or 8 of these still around. And as you see, there's some logos on this slide we don't see anymore, as there has been consolidation in healthcare. And hopefully, is that good for the community? And what is it going to do for Grand Rapids? What about U of M Health? Well, we know that the mothership is in Ann Arbor. It's been the top-ranked hospital in Michigan for a number of years. Very highly ranked medical school, clinical, and research programs. Here in Grand Rapids, we have U of M Health West. Just over a year ago, Sparrow and the satellite hospitals joined the U of M Health Network. And just a few weeks ago, a strategic alliance was signed with U of M Health West and Holland Hospital. Although there's been more hospitals joining the network, we still continue to follow 3 goals. Number 1, our goal is not to be the biggest, but certainly to be the best healthcare system we can. Number 2, we're going to train the next generation of healthcare providers. And number 3, we're going to advance care through clinical and basic research. Again, working to provide the right care at the right place at the right time. And obviously, West Michigan is a big part of that plan. As I was looking at the health check data, again, fantastic booklet, took a lot of reading, there's a lot of information there. I noticed that the expenditures for coronary artery disease in Grand Rapids were greater than Detroit. And then when you adjust for the risk factors, it's even much greater than Detroit, which I find interesting. Of course, as a cardiologist, I find it interesting, right? But it's odd because in Detroit, there are more comorbidities than there are in Grand Rapids. But yet the cost of open heart surgery in Grand Rapids is greater than Detroit or Flint. And the largest city in the country with only one open heart surgery program was Grand Rapids. So at this point, as we're talking with the leaders of both the U of M and a few other leaders, we said, is this time to be competitive or the time to be collegial? How best do we care for our community? We thought it was best to be collegial. So we partnered with our colleagues at Trinity Health and created a new open heart surgery program. We applied to the state, received a CO1 certification for that. The first new open heart surgery program in the state in over 16 years. We performed our first case just about 16 months ago, this combined program. Happy to say, we planned to do 50 cases the first year, let the nurses and doctors and anesthesiologists, everybody get working together. We actually wound up performing 122. And in fact, in the 16 months, we performed 184 cases. The STS, the Society of Thoracic Surgery, is a national organization that every heart surgery program sends their data to, and they tell you how you're doing compared to other programs in the country. They give you kind of benchmarks. Well, you can see our mortality benchmark was a third of the national average. For transfusions was a half. Getting off the ventilator in less than 6 hours, we're 20% greater. Nobody had renal failure. Length of stay was almost 1.5 days less than the national average. And again, readmission rate was about half. So again, working together, creating a better system for our community, we had really nice results in just 16 months. And in fact, what we really did was we provided choice and options for our community in West Michigan for the cardiovascular care. Very interesting talking to some healthcare insurers. Our preliminary data is already showing that the cost of healthcare, open heart surgery in West Michigan, has been decreasing in these 16 months. So again, we're beginning other programs because of this collegiality. And other good news is we're going to be doing some regional programs such as research programs in conjunction with the Franklin Cardiovascular Center in Ann Arbor to bring state-of-the-art research and new therapies and cares to our community here in West Michigan. So again, doing all this, trying to provide the best care at the appropriate price, keeping local care local. That was open heart surgery. What about oncology? Well, you know, oncology is an interesting field. There's a limited number of these so-called fellowship-trained oncologists, and they're really difficult to recruit anywhere, especially West Michigan, but all cities. There's very few FDA-approved clinical trials here in West Michigan. So again, if we really want to improve oncology care here in West Michigan, should we be competitive or should we be collegial? Well, again, we turned to our partners at Trinity. We developed the Cancer Network of West Michigan. And because of that, just in the last 6 months, now the network started a little slow because there's this little virus called COVID that kind of slowed things down for a couple of years. But nonetheless, just in the last 6 months, we've been able to recruit 7 specially trained medical oncologists and 3 oncology surgeons. And again, we're also very excited because we're now going to be doing clinical trials with the Rogel Cancer Center in Ann Arbor, one of the top 20 rated cancer centers in the country. So again, really advancing care in West Michigan, working together to do that. What about population health? Certainly, with our primary care and specialty care networks, we've embedded some nurses, managers, social workers, pharmacists into the clinics to help these patients right at point of care. We've tried some convenience hours, nighttime and weekends, so it's a little easier for people to get there. We improved our integrated network structure. We simplified scheduling procedures, focusing on Medicaid and Medicare members, because they sometimes have the hardest time getting some of the scheduling done. We had navigators to assist patients who have social determinants of health and language barriers. Really working with these patients to get pre-authorization approval, because we know how frustrating that can be. You go to get your test, you didn't have pre-authorization, you can't get this done. And certainly educating and obtaining access to healthy food, we've heard about, is crucial to having good health care. Again, by doing all these measures, what we're seeing are decreased hospital readmission rates. So again, hopefully, a good indication of improved health care. I was glad to hear someone talk about burnout. Has anybody seen any healthcare providers in these situations. Burnout is a huge problem. We started the Office of Professional Wellbeing. And with this, our mission is to play an active and engaged role in measuring physician and advanced practice provider wellness while developing strategies to increase their well-being, not just patients, but their well-being also, because burnout has become a huge problem. As we do this, a quadruple aim, the first of which is always enhance patient experience. Our goal to improve population health, reduce costs, and again, improve the work life of our healthcare providers. Now, how do we do that? Well, to prevent burnout, we've came across interesting statistics. We know that many physicians can spend up to 2 hours a day on the computer for every 1 hour that they spend taking care of a patient. I don't know of anybody that I went to medical school with, but that was their goal when they went to school. They like taking care of patients. Many physicians, because of all this administrative workload, are either retiring or pursuing non-medical roles. So what do you do about it? Well, we actually came across this program a few years ago called DAX. And DAX is interesting. It's essentially voice-enabled software that works on your cell phone. So that when you go in to see a patient in an exam room, you don't take a computer, you don't take a clipboard, you don't take a pencil. You go in, you sit down, you look at the patient, and you talk to the patient. Novel concept, sit and talk to the patient. And while you're talking to it, the phone records the conversation, sends it to the cloud, and the cloud actually, the program, creates the clinical note for you. So that within a minute or so of leaving the exam room, your clinical note is done. How about that? We've noticed that we can save about 8 minutes for every patient encounter. Now, if you can imagine, if you see 15, 20 patients a day, it's a lot of time. It's a lot of time of non-direct patient care, the kind of care that frustrates healthcare providers. We have certainly have found that we've decreased disengagement burnout as in the loss of motivation. People just kind of giving up that I can't do this anymore. Because of how DAX has worked and our physicians and nurses are enjoying their work, interestingly, they are so excited now. They're actually seeing about 21 more patients per month. And they're doing what they went to school for, take care of patients, not type on the computer. Our next step is to take DAX and expand it to our nursing notes. So our nurses can have the same level of engagement and enjoy their job a bit more. Real excited about where this is going. One last slide to talk about. During COVID, virtual exams, virtual reality certainly became very helpful. Let us help many, many people around the community, around the state, around the country. But I think it's important to remember sometimes virtual exams can be helpful for behavioral health, maybe even diabetes, hyperlipidemia. There's some exams and discussions with the patients that maybe a physical exam and in person is really helpful. Came across this young man recently, 44 years old, healthy, hadn't had a physical exam for a couple of years because of COVID and needed to go back at his routine checkup. Called, make an appointment, and, oh, you're a healthy person, would you like to do it virtually? No, I'd like to see a physician. Well, they went banter back and forth, and, well, if you come schedule the appointment, it's going to be about 3 weeks. We can see you virtually in a day and a half. He said, well, I'm healthy, I'll wait for the 3 weeks. So he went for the 3 weeks, had his exam, and healthy person, things look good. But he has this little spot on his scalp, but you look here, see, right in the middle. Had a little biopsy. That little scalp was something we call melanoma. Had a wide resection. Happy to say he's cured. His family's going to be great. But just a nice example of how not everything can be treated virtually. And as we as healthcare providers see our patients, we need to make sure that they get the right care that they need. And certainly some of the underserved areas, we can kind of route them into virtual care. For things may be helpful, but for some exams, make sure we get them the care that they need. And the last slide I have for you. I grew up in Detroit, 6 Mile and Gratiot. Spent 29 years in Detroit, spent 11 years at Wayne State University. And I got to tell you, this was really one great year. Thank you for having me here today. Thank you for the symposium, and happy to answer any questions after.
Good morning, everyone. Thank you for having me. It is, I think we can say it's spring already with this weather outside. I'm Rima Shah. I'm a primary care physician. I'm an internist by training and also serve as the Chief Medical Officer for Corewell Health West, and also my responsibilities include the ambulatory medical group as well as population health. So I wanted to start off with this slide. Basically, I think one of the most important things that happened with COVID was it really shed light on the disparities that a lot of my colleagues here kind of talked about, and brought attention to this, that this is not okay and we need to do something about it. I wanted to start off with sharing one of my friends who shared with me. She is a transgender, and she has had such horrible experience in accessing healthcare that she once shared with me that I would rather die than go to the emergency room or go to a healthcare facility because of the experience that she has had in the past. And that is not okay. And keeping that in mind, brought that up at our meeting, and it came up from the team members that let's create something where we provide training to our team members and our providers so that every individual in our community feels respected, feels that they are treated like any other individual. And since then, we created an LGBTQIA plus expert improvement team. We had providers and patients and operation leaders, physicians, pediatric physicians, specialists, who all came together and developed this curriculum, which then became, if every practice would go through that training, including the team members, they would get a designation for safe and affirming designated practice. And since then, since we rolled that out, we've had 32 practices that have received that designation. So I think I share this story because I think sometimes out of crisis and things that happen, there are things that come out of it that we can really make an impact, and it sheds light on that. So coming back to this, COVID-19 stressed that there is disparities and there is a lot of work that we need to do. We talked about mental health trends, and we see that also at Corewell Health, our patients in primary care, we see that year over year, we are seeing an increasing trend of depression or diagnosis of depression. What we are doing for that. In primary care, we screen any patient who has touched our healthcare facilities. If it's primary care, it's inpatient, emergency room, we screen them for depression and anxiety and suicidality. And if they are positive on those screening tests, then they are connected with the appropriate resources. We have also expanded this a blue envelope program, which is to check for suicidality and then really take action according to that. We've partnered with local schools because we were hearing from our communities that the rate of depression, anxiety, suicidality is also increasing significantly in our school system, in our kiddos. So we have partnered with our school system and provide that support virtually, as well with our behavioral health specialists, and screening them for that and providing those resources. We have embedded behavioral health specialists in all primary care offices. And of course, access is the biggest thing that we're all challenged with. So hiring more psychiatrists, pediatric psychiatrists, as well as adult psychiatrists, behavioral health specialists, medical social workers, and then also developing those community partnerships with Pine Rest and HDVCH, a partnership that we will be rolling out as well. So I think access is the most important thing, that there are different ways of how we are implementing to provide that care for our patients. When we move towards smoking trends, exactly what our professors talked about and what the report shows and colleagues shared in their healthcare systems, seeing the same thing, that smoking rates are decreasing and e-cigarette and vaping use is increasing. As you can see, our current smokers in our attributed patients in primary care is 7.4%. But when we go deeper and when we ask patients who have said yes, that they use some kind of tobacco product, about 75% of them for patients aged 30 or less, there is 75% of them are using e-cigarettes or vaping. What we are doing about this is we have created teams, smoking cessation team members, tobacco and nicotine specialists, and we connect them. We provide services to our community as well as to our patients without any cost. And we provide resources, education, and even group sessions either in person or virtually. We also have connections and provide these teams to go into schools and provide that one-on-one counseling and support to to our students, as well as sessions. We help school members to create policies and curriculum development as well. Talking about healthcare utilization, absolutely higher utilization of ER we are seeing, as well as a lot of ambulatory services. We are seeing an increased uptick as well. And I think there are maybe a few other things. We see our aging population, 65 and older, and so the needs and healthcare needs are increasing. We are seeing a significant shift from inpatient to outpatient. So what could take 6 days and a procedure that would have been done in inpatient, now we are doing them in outpatient standalone locations. Length of stay is a big initiative for all of different hospital systems and really focusing on that. So now we are discharging patients that are appropriately, but much sooner, because there are services that can be provided in ambulatory spaces. So the access, again, I feel because there is so much primary care, there's so much walk-in clinics and urgent care, are we pushing patients back into the emergency department? So I think those are important things that we're focusing on, developing different ways to provide access to patients. One of the most important things is to really think about that not every patient needs to see a physician or an APP. How do we use multidisciplinary teams? Who are the patients that can be seen by an APP? Or are there things that the APPs are doing can be done by an RN? If a patient has high blood pressure, do they really need to see a physician, or they can see the pharmacist, or they can see other team members? And this is a big shift in the way that we physicians are trained, and we have to really think differently because workforce is being squeezed. There is a lot more demand, and we have to think differently as to how we are using our team members in the appropriate way, shifting the work to the right provider for the right patient, for the right issue that they are bringing up. So I think that is a big shift that we're moving towards when we talk about population health and value care. That is the focus of that, is the right patient with the right provider, the right location. Burnout, absolutely. It's a reality. We talked about in this report more of team members and physicians and clinicians who are burnt out inpatient. We see this all across. Primary care providers are burnt out, and we see that women physicians are much more burnt out as well. So the structure, the way that we have designed our practices, we have to think differently as to how to address those burnout. Again, as I talked about, the right team member having a multidisciplinary approach is something that would help take some of that redundant work that doesn't need to be done by a specific clinician, and it can be handed to another team member. DAX is something that we have rolled out, and our providers love that because it really takes off a lot of that administrative work that is currently they're doing that as well as seeing patients. Now, I will share with you that in-basket work is one of the biggest reasons for burnout in our providers and APPs and physicians. When we looked at the data in primary care, and in the medical group, we saw 500 MyChart messages pre-pandemic, and that increased to 1.6 million post-pandemic. That is significantly, this is not sustainable. Seeing patients all day, and then you need another FTE doing just the in-basket work. So what we did in order to address that, was to create a structure where we call them inboxologists, an APP for 3 practices who just does in-basket work. And the physicians and the APPs just see patients. Of course, there are some in-basket work they still have to do, but that has, I recently rounded in the practices where we had inboxologists, and the providers told me that they have found joy in work again. And that was like, music to my ears. This in-basket work is, I think, one of the the highest reason for burnout. And if we can find a solution for that, I see light at the end of the tunnel with this inboxologist. We are now expanding this further, and we will see how it rolls out, because primary care specialty is different, but we are going to evolve, and we are very, very excited about that. Going towards income disparities, we talked about that, and I'm not going to go into the numbers because that was already discussed. But how can we now address these disparities? So one of moving towards value-based care, I feel, because it is focused more on outcomes, the things that we used to say, this is not my problem. If a patient comes late, 5 minutes late, oh, I'm not going to see you because you're 5 minutes late. Or if a patient has 3 missed appointments, I'm going to discharge you, they'll send a discharge letter. That is no longer, this is our problem. If the patient is 5 minutes late, 10 minutes late, 1 day late, we still need to see them. Because if we want to make a difference in their outcomes, all of these issues, all of these hurdles, we need to make sure that we create a system, we help them overcome these disparities. So I will give you an example of community medicine clinic. It is a primary care practice that is located on 75 Sheldon, and it serves some of our most vulnerable patient population, the underserved patient population. They have unique needs. They have chronic pain, behavioral health needs, substance use disorder, many social determinants of health disparities like homelessness and transportation issues, childcare, housing. So we really thought that in order to make a difference in the lives of these patients, we need to give the resources specific to the needs of those patient population. So we embedded a psychiatrist in that practice, in a primary care practice, having a psychiatrist, a behavioral health specialist, a pharmacist, a physical therapist who is embedded in that practice, community health workers. And we said it shouldn't be like schedule appointment. If a patient doesn't even know where they're going to spend the next night, how can you tell them on May 12th at 2:30 you come for an appointment? That just does not make any sense. So we had a walk-in clinic for those patients. You come in whenever you can, and that's when we will provide you with primary care. And for those of you, if medical loss ratio, I'm a geek, population health, value, but they had an MLR, the highest of 129. And by just doing this, we decreased it to 85. Now that is unheard of in our Medicaid patient population. The right thing is to really look at what are the needs of our patients and then serving and providing those resources to help overcome those barriers. We are expanding that. Amplify GR is a similar practice that we will be opening in Boston Square. And that will be exactly similar to what I just talked about as CMC, providing all of those resources that will address the needs of the patients that we are serving. And then an exciting thing is the SDOH dashboard that we have created, which is, it will take all of the information of those patients. If they have any social determinant of health barriers, we look at their outcomes, diabetes, hypertension, hyperlipidemia, they're not controlled. Let's look at what are do they have any social determinants of health barriers? And if they do, is there a correlation, and do we need to really address those barriers in order to have an impact and provide that equitable care? So this is my last slide, I think. And thank you very much.
Thank you for having me back this year. It's always a pleasure to be back in my alma mater. Appreciate it, even though I don't ever recognize all the buildings and everything that's going up around here. It's so fantastic to come home and see everything here. So I think I'm doing this myself here. All right. So today I know we're on sort of a quick time schedule. So I just want to provide an update on a couple things. Our work as an overall department, our progress on our Medicaid renewals, required because of some of the federal changes occurring on the epidemic. Our priorities related to health outcomes, including some of the most recent investments and budget recommendations that are relevant, I think, to what we're discussing this year at this health check. So to start, I just want to level set on the department and some of the ways that we interact with people across the state through our state and federal programs. The mission of the department continues to focus on providing services and administering programs to improve the health, safety, and prosperity of the residents of our state. The goal is to deliver health and opportunity to all Michiganders, to reduce intergenerational poverty, and to promote health equity. While we have a lot of work ahead when it comes to continuing to strengthen the healthcare workforce, improving access to behavioral health, and addressing inequities and the social determinants of drivers of health, I am so proud of what our employees and our partners, like many of you in this room, have helped us to accomplish in fiscal year 23. This is just a quick snapshot of how we were able to provide support health and opportunity in communities across the state in that 23, which ended September 30th. We cannot do this work alone. Many of you listening and on today's panels contribute to this work. So I just want to say, first and foremost, thank you so much for everything that you do for your communities. We've been working a lot on the Medicaid renewals as a result of the ending of the public health emergency. When there were federal changes that required every state to start making their Medicaid redeterminations and renewals last April. This has been, and this is a huge understatement, a massive undertaking. I'd like to recognize our employees in the Medicaid office, our Economic Stability Administration, our county offices across the state for all of their hard work, their overtime, and finding solutions to the many challenges that they've had along the way. If you don't know, our Medicaid rolls went up to around 3 million throughout the pandemic, and we're normally at around 2.2. So significant increase in the number of individuals that were on, and we normally do our redeterminations every 12 months. Federal government said no more redeterminations, so we're doing 3 million redeterminations in the span of 12 months. It's amazing, actually. So we have been working so closely with many of our partners, helping to share information with our beneficiaries, hosting community events, and helping people fill out their forms in communities across the state. We will complete this redetermination process in May. However, despite the challenges and the scale of this effort, Michigan continues to be a leader in supporting our Medicaid beneficiaries, especially in finding innovative ways to make the process easier, increasing awareness and education, and helping our eligible residents retain coverage. So to highlight just a few of the strategies that are shown here, we renewed eligibility for people who are on SNAP or TANF. We worked with managed care plans to support them in assisting people with their renewal forms. We extended the time frame to return paperwork for people to give them as much time as possible to return their materials. And CMS allowed us to adjust our processes to reinstate more individuals who were disenrolled for procedural reasons. Federal guidance says only a government state employee can do the actual eligibility. So even though our partners were able to help fill out forms and do all of that, every single one of those pieces of paperwork has to go through one of our state employees. So getting the additional time for that has proved immensely helpful. In addition to continuing to send letters directly to our beneficiaries, we launched a constant, comprehensive communication strategy to reach people across communication channels, to let people know that changes were coming and that renewals continued. So this included TV and streaming services, radio, webinars, working with stakeholders, and going to events across the state. We also, if you go get gas, you have gas station TV. One day I heard Medicaid renewals on my gas station TV. So I knew my staff had done a great job because it was everywhere. I was really excited. This also shows some of the many ways that we have taken action when CMS released strategies that allowed us to simplify the process and reduce the risk of individuals who are losing coverage. So as a result of this work and some of the flexibility afforded to us by the federal government, we were able to significantly increase our passive renewals. Passive renewals essentially means that people don't have to verify a lot of their paperwork. We can pull their information electronically from the unemployment agency as well as the federal government and tax information and do those renewals automatically without really having to touch the beneficiary. We were able to increase from our first month about a 15% passive renewal rate to month 3 to a 45% passive renewal rate. So that is about 60 to 70,000 individuals per month that were being renewed passively. That's pretty significant. We were also able to confirm that many of the people who were disenrolled due to procedural reasons were because they had other insurance available to them, which was really important to us. So for people who are disenrolled and need assistance identifying other insurance options, we continue to work really closely with the Department of Insurance and Financial Services and other partners throughout the state to make sure that we're connecting people to information about affordable coverage. And earlier this month, we announced that according to data through December, and as we look to the end of our redetermination cycle in May, we are on pace to have a total enrollment similar to that of March of 2020, which is incredibly significant. DIFS, Department of Insurance and Financial Services, also announced a couple weeks ago that enrollment on the exchange is at one of the highest levels ever. So I would say we were pretty successful in what we were able to do with our redeterminations. Continued priority of mine and something that everybody has touched on this morning, which I appreciate, is improving access to healthcare overall, but especially to continue to improve access to behavioral healthcare services. Everyone deserves access to behavioral health care where and when they need it. Our most recent budgets have included significant investments in access to behavioral health care, which include increasing the number of programs based in schools and on campuses, efforts to establish crisis stabilization units and psychiatric residential treatment facilities that will take pressure off of emergency departments, and expanding our certified community behavioral health clinics. In addition, as part of our work, we're working with stakeholders to improve access to the array of coordinated care for children. We were also able to begin the disbursement of our opioid settlement dollars. We have continued to be a leader in distributing those funds and ensuring that care, health, and well-being of residents in need. And the National Governors Association actually recognized our state as a national leader in harm reduction efforts. Congratulations to all of you. MDHHS has been authorized by the legislature to invest a total of $62.4 million of our initial opioid payments into our remediation efforts. These initiatives will support evidence-based programming and address and reduce harm associated with the opioid pandemic. Settlement funds will help address the misuse and abuse of opioids, as well as treat and mitigate opioid use and related disorders. And our aggressive rollout plan includes the launch of a website with more details on our spend plan, our state resources, and other data. I think that was rolled out a couple weeks ago, actually. So something else that everybody touched on with burnout and our workforce. We know that probably the most important part of improving access to both physical and behavioral health care is also making sure that we're working together to strengthen our overall healthcare workforce. This is something I continue to have conversations with every health system about and others about how to identify solutions. And I just want to share, this is something that the state also struggles with. We do have 5 psychiatric facilities, and we've had as much of a problem as everyone else in trying to retain and attract talent to keep us moving at our optimal or highest capacities. Our most recent budgets have included investments to strengthen our workforce, which include expanding the student loan repayment programs and scholarships and increasing wages for workers. And we will continue to have conversations and work with all of our partners on this issue. The governor's fiscal year 25 budget presented earlier this week will continue this trend of investing by shoring up our behavioral health care workforce, expanding clinic sites, and enhancing capacity to respond to children and adult behavioral health challenges. If you want to tune in next week to the subcommittee hearings in the legislature, I will actually be presenting a lot more detail on the governor's recommendations for our departments. And I'm really excited about the opportunities that we have coming up in the coming fiscal years for investments. And then finally, as we heard from every presenter, addressing inequity is a critical part of improving health outcomes in Michigan. In recent fiscal years, including the current year, we've invested the recommendations of the state's Racial Disparities Task Force and in other programs aimed at reducing inequities and health disparities from moms and babies through older adults. We established and expanded Healthy Moms, Healthy Babies, maternal and infant health programs that began with Governor Whitmer's first term to provide professional doula services for people with high-risk pregnancies, new moms, and families. We made sure that services and programs to support Medicaid-eligible moms with everything from lactation to addressing postpartum depression continue for a full year after birth, extending that from 60 days to a full year. That's significant. We increased home visits and we invested in birthing hospitals and regional collaboratives that provide support and connections to resources for families. Among other initiatives, we've also invested in a pilot program designed to address leading causes of health disparities, such as lack of healthy foods, by concentrating our resources. The establishment of healthy zones bring community members and resources together to address barriers for options for food, housing, and other built-in environmental factors that we know contribute to health disparities. Our mobile health units are designed to address barriers for accessing care, meeting people where they are, and offering preventive health care, and if needed, referrals to other services. Access to critical care for sickle cell disease and targeted public education on uterine fibroids, both of which disproportionately impact Black communities. In addition, we are continuing to work on improvements to the collection of race and ethnicity data, including information that will help assess the impact of key initiatives. This is a really important piece that we've opened up during the pandemic, is that we're not actually collecting data on all of our programs that we can compare with each other. We don't really know who we're missing and who we're helping. And so we have had a very targeted initiative internal in the department about data collection and equity. This week's fiscal 25 budget presentation did include further investments in Healthy Moms, Healthy Babies, the continued implementation of and recommendations from the Racial Disparities Task Force to support those community-based health clinics and other mobile health units. I do want to mention that the state of Michigan during the pandemic was incredibly deliberative and thoughtful when it came to disparities. As you all know, Detroit was devastated by COVID-19. It was awful. It was one of the most awful experiences I think that many people had. The focus that the governor and lieutenant governor had on racial disparities and bringing together a bunch of experts in the state leveled out the disparities in death between Blacks and whites in the state of Michigan for COVID-19 by the end of 2020. That's how significant and targeted our efforts were. So we know that we can accomplish closing those gaps when we really want to. Last month, we hosted another Social Determinants of Health Summit to engage stakeholders and recognize our progress to date and launching phase 3 of our statewide strategy. And as I mentioned last year, this roadmap is a framework to engage the public in this collaborative upstream approach to remove barriers to social and economic opportunity. Our attendees discussed best practices from other states and our recent work and included the launch of a community health worker pilot program at several of the clinics that had been COVID-19 neighborhood test sites. I'm really excited about that. The Racial Disparities Task Force funding really helped fund that. And we'll build on that in this coming year. We expanded Medicaid coverage to include community health worker services. Means that we are reimbursing for community health workers through Medicaid now. That's about 10 years in the making on my part, and I'm really excited to see that going into effect this past January. To address housing, in partnership with MSHDA, we established the Good Housing, Good Health program to increase and promote housing stabilization resources. The governor also recognized this in her fiscal 25 recommendation by earmarking a significant investment in housing across the state. And in addition to these efforts, the two main areas of our focus in phase 3, launching the social determinants of health hubs by our local health departments, and incorporating our health in all policies. If you aren't familiar with that term, it's a decision-making approach that seeks to ensure all policies have neutral or beneficial impacts on social drivers of health. If you want to read the full roadmap, that is up on our website, and the governor's presentation continued to focus on our success with social determinants. Finally, the last item that I always want to touch on is to mention our Keep Kids Safe agenda. People don't always think about our human services programs when they think of health, but our Keep Kids Safe action agenda includes efforts to address social determinants and drivers of health across all 5 pillars. We know that if we can provide families with economic support, it's more likely that children can remain safely with their parents instead of being placed in foster care. And if foster care placement is needed, providing these economic supports can make it safe for the children to be reunified with their parents. So one of the initiatives that I'd like to highlight today is our Family Impact Teams project, or our FIT teams. FIT embeds our family resource specialists with the department's child protection and foster care staff so that they can support families in applying for benefits and Medicaid and connect them to other economic supports. The first phase of this project began last August in 12 counties, and in just the first 2 months, FIT delivered services to more than 500 families across the state. We will continue to expand this model across the state from Southeast Michigan to Northern Michigan and in the UP by the end of the year. We have a lot of challenges as highlighted today, but I do want to make sure that we take a moment to acknowledge the incredible progress that we are making and to continue to improve the health and prosperity of Michiganders. So I'm excited about the opportunities ahead. We have again this year, and I really look forward to the ongoing work that all of you are doing. So thank you very much for having me again this morning.
Thank you, Elizabeth. And thank you to all who shared their thoughts and ideas this morning with innovative solutions and strategies. Thank you again for the thought-provoking presentation, discussion, as well as to our sponsors, Blue Cross and Blue Shield of Michigan and Blue Care Network, as well as Priority Health. This concludes our program. Many thanks to everyone for attending in person and also live stream as well. Have a wonderful Friday and a wonderful weekend. Thank you.